Good afternoon, Peter Goertz. I'm a psychiatrist. Taking shortcuts as a doctor, is it worth the risk? What made me think of this is I saw a patient recently and I was talking with her and she seemed more or less euthymic. Her mood seemed okay. There was a question as to whether she was suicidal or not. But then I ended up speaking with someone who knew her with the patient's consent. And it turns out she had notified various people of wanting to kill herself that same day when I saw her. So the picture became a lot clearer. She had not really admitted to suicidal thinking when I spoke with her directly. So it can be quite problematic if you don't get additional information from people who know the patient. And that would be a shortcut. So taking the shortcut not to call someone who knows the patient, as long as the patient's agreeable to you calling, of course. And another patient I saw this past week was felt to possibly be psychotic. She'd come in acting very strangely, saying her name, but essentially nothing else. And then when I got collateral information, the question came up, maybe the patient was having seizures. So it may not have been a primary psychiatric issue even. So again, really important to get additional information sometimes. Same thing with looking at the state prescription monitoring profile, so what we call the PMP. I found out that a patient, for example, had been prescribed Klonopin, but the people whom I was doing the consultation for, so the hospital staff, had not been aware of that. So she had not been getting Klonopin since admission, which I think was a few days, and people can withdraw from Klonopin, of course, if they don't get it. Similar situation happened with Ambien this past week. So again, it can take a little time to check the state PMP, but often well worth that time. And in general, medication reconciliation, so figuring out what medicines was a patient prescribed, and then next step, what medicines was the patient actually taking at home, which can be quite tricky because patients may not be truthful, they may not remember, may be disorganized. Even someone who knows them may not be sure what they're actually taking or not taking. And that can take quite some time to tease out as best you can. So do you as a psychiatrist need to always do that yourself? I don't think so. I think any staff member can do that. For example, or not any maybe, but a nurse, for example, could do that quite competently. And that is something you can delegate potentially. On the other hand, sometimes it can be confusing and sometimes you really need it quickly in order to make a decision. Does this patient need to be admitted to a hospital or not? So sometimes you do need to actually try your best to go through all the medicines the patient's taking at home, medical and psychiatric, with the patient and or even with someone else, let's say the husband or the wife at home, one by one, and that can take a lot of time. So in my experience, sometimes you can delegate it, sometimes it's not a good idea to delegate it. For example, things can happen. A patient had been prescribed clozapine at home, and the hospital staff, for the first few days of hospitalization, had not been aware that she was taking clozapine at home. And when I spoke with the patient's mother, she mentioned that, but by then, it was quite some time after the patient had been admitted, and at that point, the clozapine would have been necessary to titrate the clozapine back from a low dose, which can be or is time consuming, and then the patient doesn't get an adequate dose for some time. So legwork can be very important. So this patient missed out on her clozapine, and that may have had something to do with the fact that the patient was having major outbursts in the emergency room. So when considering shortcuts, you certainly want to think about the safety of the patient. You're human. You want to think about your career. If you have enough bad outcomes, that's not going to look good. So, and of course, then there's the ethical aspect. You want to do right by the patients, and you want to be able to look at yourself in the mirror after you've made certain decisions or after any decision. So it's a judgment call. I don't feel that it's a bad thing, that it's always a bad thing to take shortcuts, but you really want to use your best judgment as far as which shortcuts you want to take. And that can be tricky to make those judgment calls. For example, things potentially that can be left out in a history, let's say in an emergency room patient where the patient's suicidal, you may not need to get a family psychiatric history. You may not need to get a work history. You may not need to ask them about their hobbies if you're in time constraints. Even though it's good to ask those things because it's good to have as full a picture of the patient as possible, if you're feeling that you don't have much time, certain things often can be left out safely, in my opinion. And checking lab work can be time-consuming also. Another very important thing to check lab work, make sure you know what's going on medically as far as the lab work. But there are ways maybe to save some time checking the lab work also, because one thing potentially that can save time is if you look at all the lab work results in the computer, the ones that say normal next to them, maybe those you can leave out looking for the exact numerical value of the lab work and just check the ones that are abnormal. On the other hand, even that can be tricky because let's say a patient has a B12 value of 210, that might say normal, so it might be within the reference range of that particular lab. However, it's quite marginal, very close to being low. So tricky if you want to save time and take shortcuts, but sometimes possible in my opinion. And another way to save time is to delegate things. So sometimes it's entirely possible to delegate getting collateral information from the family to, let's say, a nurse or the primary team who asked you for the psychiatric consultation. So ultimately, you want to have the minimum amount of information to ensure that you feel comfortable making a good assessment of the patient, and then also making what you feel are appropriate recommendations. So kind of a vague statement, but your gut will tell you when you've reached that minimum amount of information. And again, you want to be able to look at yourself in the mirror the next day or any time and feel reasonably comfortable with the decisions you've made the previous day or any day. And ultimately, if you're being told you're not seeing enough patients, if you feel that it's not possible on average to see more patients because then the quality would be below what you feel would be a minimum standard, then you may need to change your job. Thank you. Bye.